and welcome to A Deadly Silence. I'm your host, Larry Curtis, and it is the goal of all of us associated with this program to bring you current and educational information concerning alcohol and drug addiction, not only within the city of Brockton, but throughout all of our South Shore communities. Today, our guest is Heather Kennedy. Heather is a program director for the Cope Center, which is part of BAMSI, as I understand, Heather.
Yes, it is.
Welcome to our program, Heather.
Thanks for having me.
Pleasure to have you here. Tell us a little bit about yourself, Heather, and how you came to work for the Cope Center.
Okay, I have been working for BAMSI for about 9 years now at the Cope Center, which time seems to fly by. And we're funded by the Office of HIV/AIDS to do basically HIV testing with active injection drug users. And as you're aware, in this neighborhood, that generally means heroin addicts. So we've been working, doing risk reduction counseling with them for a really long time. And the program itself has been right on Pleasant Street since 1996. And we've been doing testing services since 1989 in Brockton.
Now, BAMSI has a much broader scope of services that they have out there. Can you share with us with some of those?
BAMSI is a very, very large nonprofit organization, and it has multiple divisions. I'd say probably 85% of it is for developmental disabilities. So they have a lot of residential homes where people with developmental disabilities or behavioral health issues can live, and it's their residence. And they also have a lot of outpatient services, so mental health services, day habs for people who might need a little bit of support service during the day. And then they have the whole host of public health programs, whole host meaning about 15% of the agency. So we've got the WIC programs and the early intervention programs, and then we've got the HIV services. So if somebody's HIV positive, they can have medical case management, but we can also HIV test them and work them through a risk reduction counseling process while they're actively using drugs or engaging in other high-risk behaviors.
As part of the residential programs, are these long-term residential programs at the behavioral?
That is their home. That's their permanent residence.
That is their permanent residence, and BAMSI manages the services necessary to support those residents.
Anybody from brain injury to severe mental health or developmentally delayed individuals, or it's now just a service that they provide in their home.
And
for
these
them.
are individuals who don't necessarily require hospitalization, but can function in a home environment.
Yes.
With some support mechanisms.
Yes, and one of the major goals for BAMSI is to help people feel engaged in their community and help feel a little bit more of a sense of self-worth, and that fits right in with what our program goals are also. So we all kind of have that one tie into services.
You mentioned that, for 9 years, the Cope Center, HIV testing, as well as, some of the addicts out there. It's interesting because we don't hear a lot about HIV anymore in the news out there,
No.
Because of obviously the opioid heroin epidemic that's been, prevalent throughout the South Shore communities. Tell us a little bit about the background of the HIV addict and what's happening there.
Well, we're actually working with two very distinct cohorts of individuals. So there's a whole cohort of individuals that they're now like 40 or 50 years old, and they progressed over a lifetime of drug use to shooting heroin. So they might have been married, had kids, had jobs and careers, and kind of subsequently lost all those things. And they'd kind of come up in the age where their friends were dying of either HIV or liver disease from Hep C. And the purity of the heroin around that time was maybe 30%, and it wasn't as pure as it is now. So their real concern wasn't necessarily the overdose epidemic that we're looking at now. Their real concern was the infectious disease piece. Mm-hmm. And now we are sort of shifting into looking at a second cohort of individuals who are starting to really use, which are the 20 and 30-year-olds whose brains aren't necessarily fully developed. They may or may not necessarily have had a mental health diagnosis. They may or may not be self-medicating for a mental health diagnosis. And they sort of went from, or generally speaking, they'd gone from, maybe experimenting using some pills over a short period of time and sometimes very quickly progressing into shooting heroin. So they may not have had, wives and girlfriends and husbands and boyfriends and kids and homes and jobs and careers and then lost all those things. They might have kind of jumped straight from high school to maybe even into college to now I'm hooked on pills and now I can't afford my habit and I'm using heroin. So we're looking at the second cohort of individuals whose real concerns are overdose because their friends are dying of overdose. But they're not necessarily really concerned about the infectious disease piece. But coming from the infectious disease, perspective, we know that it's somewhere upwards of 90-95% of the people who are entering treatment programs have hepatitis C, and we're probably going to need new livers in 10 years, which is like the next thing we're going to be looking at for public health.
The next level of a healthcare crisis
for
the addict that's out there.
Exactly.
Mm-hmm.
And by the time you feel symptoms of Hep C, if you haven't gotten a test, you probably need a liver transplant, and it's kind of a little late for that. So we're looking at the folks who are coming into HIV case management, brand new with a new HIV diagnosis, being those who didn't necessarily get an HIV prevention education or drug education when they were younger, and now somehow contracted HIV either sexually or through injection drug use. Mm-hmm. And all it takes is one or two, and with a whole cohort of individuals who didn't really get that education, now they're blatantly and rapidly spreading Hep C everywhere and not really thinking much of it. And some of them are spreading HIV and contracting HIV and not realizing that it's still even relevant.
That's by not only shooting up using needles, but mm-hmm. also through sexual contact.
Yes.
That, and these younger individuals may not even realize they have the Hep C or HIV at a certain point in time because, as you said, there's been no testing done.
Exactly. And their biggest concern is overdose and not the infectious disease piece.
Right.
So it's a whole mixture of individuals that we're looking at with very different priorities and very different life experiences, and we are trying to meet the needs of all of those individuals, but the younger group oftentimes has started using, whether it was self-medicating or just kind of recreational experimentation, but their mental illness, if they have one, hasn't been able to really been pulled apart because their brains don't really develop until they're 25, and if they had any length of sobriety, it takes a significant amount of time and effort working with a mental health professional to come up with a diagnosis.
Are you seeing an explosion of the number of individuals that you're beginning to see or treat, or advise, or is it kind of a status norm? With the combined HIV and the heroin, I guess.
We have been lucky enough to be able to bring on two brand new full-time staff members this year in addition to our current staff because we are so overwhelmed.
So we're seeing an explosion?
Yes, okay. Definitely.
And I asked the question because there was an article in today's paper that, down in Dallas there was the mayor's conference held in Dallas, and it basically went on to say that heroin use increased more than 80% nationwide from 2007 to 2012. Driven by an ample supply and a crackdown of prescription narcotics. The leaders attending the U.S. Conference of Mayors in Dallas were also told that physicians in the U.S. prescribe enough painkillers to medicate everyone in the country 24 hours a day for a month. That's staggering. I mean, you mentioned that the pills is the gateway, more or less, into the heroin needle use and so forth.
I'd like to say it's surprising, but we're definitely seeing that. It's been one of those shifts that we've seen over the last couple of years where we've had more and more demand for overdose prevention, risk reduction counseling, and Narcan enrollment than we have for testing services. And it's a challenge because the state isn't really set up for that. So we've been meeting the needs of the neighborhood, meeting the needs of the communities. We've expanded a little bit further, and we work with our local coalitions, whether it's the Brockton, Stoughton, Rockland, East Bridgewater, Carver. We've been working with as many, I think it's going to be Abington and Holbrook also, just to try to work with people to get services out to them because there are no services
in some of these
other communities. We are their local service.
Okay. Well, it's kind of great for BAMSI to be able to spread its wings and begin to service more of our communities in the South Shore, but it also highlights the fact that it's a growing problem. And I actually find it fascinating when you talk about two different levels or classes of individuals. The older 40-plus group that was really HIV and now dealing with the liver crises, of that. And here we've got the younger group coming in, the 20 to 30 age group, who, as you said, haven't been educated, on the
risk
dangers,
factors.
the risk factors of what's going on there.
And you look at the fatality overdoses that come around, and a lot of the overdoses that people survive are in their younger generation, but a lot of the fatalities are actually in their 40s, 30s and 40s. And a lot of that has to do with, the heroin nowadays is much more pure than it was before, so the potency is really more significant. But you also have an addiction of tolerance. So the longer you use, the more you need to use. So the folks who might be starting out and may misuse here and there to the point where they overdose aren't necessarily putting enough in their system and are more reactive to overdose or aware of what's going to happen. And the older generation who is more concerned with the infectious disease piece, and we're still working on them to become more concerned about the overdose piece. They need much more in their system every day just to maintain. So the more you have in your system, the more likely it is for you to overdose, and that's not their primary concern. So they're the ones who are actually overdosing and dying.
In the addiction community out there, we've always seen like treatment being more or less intervention and then treatment. There seems to have been a pendulum shift to more focus on prevention. Is that something that you're seeing out there in relationship to some of the agencies you work with?
I think there's always been a need for prevention, and I think I got laid off twice working with teen substance abuse prevention in the early part of, 2001, actually for BAMSI. And that was sort of not pushed by the wayside, but this whole generation is the generation that's coming up now with the epidemic that we're looking at. And the prevention piece, a lot of the programs in the area, the coalitions in the area are really pushing the primary prevention piece. And it's really, they're looking at prevention, intervention as a group, because you're being reactionary with sort of like the secondary prevention around overdose prevention, and you're looking at the treatment phase, which really needs to happen for the folks who are lucky enough to still be around. And then you're praying that the prevention piece will work and slowly become systematic with everybody and pick up and hopefully not send any more kids down that path.
You had mentioned Narcan earlier. I believe BAMSI does supply Narcan and has supplied it for a while.
We have been a Narcan pilot site for the Department of Public Health since 2009. I think we gave our very first kit out on, I'm not going to say I think, we definitely gave our very first kit out on February 25th, 2009. And we've enrolled over 4,000 people since then. And we're literally putting the medication into the hands of people who are often first responders. So we're working with the folks who are really not necessarily inclined to call 911. We're working with them around how it would be more likely for them to call 911, but also the rest of the response piece around rescue breathing and administering Narcan, and the fact that Narcan cuts down on rescue breathing but doesn't take the place of medical attention or rescue breathing itself. And then looking to push people into treatment when they're ready. And through the coalition that we work with in Brockton, we're actually pretty lined up with, I can get a call from the emergency department saying we've seen a spike in overdoses today. I can put an advisory out, which is something a public health program would do in the event of a spike in overdoses, and we get a little bit of information.
When you say you put it out, where does it, you put it out on, like, social networks or something?
No, it is usually really localized.
Oh,
so
okay.
We don't want to advertise that we've got good heroin here.
So
we keep it really local, and it goes to the police departments and the fire departments that we work with, and it goes, a stack of them went out the door with our folks who literally were hanging them on trees and in rooming houses, in the parks where, folks who really need to know these things are going to be able to read about these things, and just understanding that this is what it looks like and this is what's been happening. People with really great tolerances are falling, or overdosing or falling out, and just to keep that in mind and maybe do a tester shot or not do as much the next time, or some of the risk reduction practices that we work with them around how not to get dead, especially folks who aren't going to be calling 911.
So in essence, even the addict, the community of addicts have to be sensitive to the potency of the different drugs that are out there.
Definitely.
And they're kind of plugged in.
They need to be. And we try to, we kind of act as that central hub, like, oh, there's a big drug bust over here. We know that reactionary-wise, everybody who went to that drug dealer is now going to have to switch to a different dealer because it's drug of maintenance unless they're getting into treatment, which we strongly, encourage, especially if there's been a big drug bust. And then for those folks who need to switch dealers, the dealers cut things differently. And if they're not used to how it's cut, we see another rash of overdoses. And you can almost see it happening, big drug bust, picking up a ton of pills or heroin off the street. And then we have the fallout with the overdose piece. And we have an excellent working relationship with our law enforcement in every single community that we work with, because we couldn't go do what we do and have them come up behind us and arrest everybody. We wouldn't be able to do our jobs.
Exactly.
We're very, very closely related with the law enforcement, but it's sort of a behind the scenes kind of thing, and we react when things happen in the community, and we have to keep our folks up to date on what's going on, because we know, just like everybody kind of gets up and brushes their teeth like 3 or 4 times a day, we know they're going to use 3 or 4 times a day. And you just have to work with that until we can get them to a place where they want to think about not using and maybe think about changing.
If I were a parent that had a loved one that I suspect is using heroin or something, and I wanted to get Narcan, how would I go about doing that?
There's a couple of different ways. You can go to a Learn to Cope meeting. They enroll people at the Learn to Cope meetings. You can come to our office. We have drop-in hours Thursday through Saturday, or by appointment Monday, Tuesday, and Wednesday. Oftentimes, I'll send my outreach team a little further down the South Shore if we've got a couple of calls from the Carver, Plymouth area. We do some of our best work at Dunkin' Donuts. We'll kind of casually meet at a Dunkin' Donuts and, go through some of the training at Dunkin' Donuts as discreetly as possible. But
And do you put on like educational, outreach programs through like different organizations, like like a YMCA or Boys and Girls Club? Would you?
We host or facilitate trainings pretty much anywhere that asks us to.
Okay.
We cannot provide Narcan for staff of other programs. Their emergency response protocol is probably 100% effective, which usually involves calling 911 and rescue breathing or CPR. But we can put trainings on for other people's clients.
Okay.
As long as they're 18 or older.
Yeah, 18 or older, correct. So other organizations, if they wanted a training session, you could put that together for them.
Yes.
And teach them. And it's not only just the medication of Narcan, it's also, like you had mentioned, the rescue breathing and positioning of the body to prevent choking and things of that nature until the appropriate rescue arrives.
How to respond, how to call 911, how to put somebody in the recovery position. And it's actually an evidence-based intervention that's used pretty much nationally, that we pretty much cover the same 5 or 6 things every single time we enroll somebody, and then kind of tailor what their risk factors are or their experience might be and help mitigate some of that.
Recently in the last 3 or 4 months, starting back in February and March of 2014, we began to see the different counties, Plymouth County, Norfolk County, the district attorneys step forward and basically get the first responders the availability of the Narcan out there. Has there been a change in the number of saves, I guess you could call it, as a result of that?
I am sure there have been. That is, with the district attorney's offices putting Narcan or making it available through the medical director for that program for first responders. It's actually an entirely separate program from ours.
Okay.
So we worked pretty closely with Stoughton to help Stoughton get their program up and off the ground. And then that medical director sort of took that and was able to expand it to like Norfolk County and Plymouth County, and I'm not sure which other counties, but I know he was going county by county. He was pretty much making that happen.
Norfolk, Plymouth, Barnstable, Bristol County down here in the South Shores areas that, we've seen a lot of good. Let's kind of shift gears and talk about babies. You know. as part of your services that BAMSI's offer, you mentioned the young adolescents, young babies, and we've seen, recently babies that are being born drug addicted.
Yes.
Can you comment on that? Are you seeing that out there?
We would not see that, unfortunately.
Okay.
We every once in a while will have a woman come in who is pregnant, and oftentimes she is either on, if somebody is addicted to an opiate and they're pregnant, the safest thing for the baby is to put the mom on either Subutex or methadone. And the idea behind that is you want to maintain the opiate addiction while the woman is pregnant for a couple of different reasons. You want to make sure that the baby is safe and doesn't detox in the womb. The baby has a much greater chance of surviving a detox.
So as the mother would be detoxing, the baby is detoxing at the same time, but is still in the womb.
And unable to be resuscitated if necessary. And the safer option between street drugs and the street life that kind of goes along with getting street drugs is either Subutex or methadone, which are both opiate maintenance medications that are used for pregnant women. And you don't have the risk of infection, you don't have necessarily the same risk for overdose if used properly, and you don't have all the street life that kind of goes around getting your drugs.
So some of the statistics that when they promote when they talk about infants being born with an addiction may have been necessary in order to sustain the life of the fetus during its pregnancy and then ultimately.
Yes, it's a little misleading because a woman could be doing everything right for 8 months and still fall into that category. 8 months is not an extended period of sobriety per se, but it is something she could be doing the next right thing every single day for 8 months, give or take, and still fall into that category.
Mm-hmm. You mentioned the Mayor's Office of Opioid Prevention here in Brockton. You work closely with them, and I think you've begun to branch out into some of the collaboratives out there.
We have been part of that coalition since before we had funding for that coalition. And we had worked with the coalition to develop their cluster of communities specific to Plymouth County. For funding purposes and statistic purposes, it was very easy for them to stay within Plymouth County. So they picked a whole cluster of communities who were ready and willing to join with them. And then we went the opposite direction because we know we can cover those communities just as well. Whenever they have an event going on, they'll call us, and we're their Narcan pilot site. We'll come out and provide services or education when it's needed. But we went and focused our attention in different directions so we could sort of maximize the expertise from the Brockton area and help cover more of the South Shore. So we ended up going West Bridgewater, Rockland, Stoughton, Carver, Plymouth. And they are Whitman and Hanson, because Whitman and Hanson have the same high school. They're at the table. They were invited. East Bridgewater, Rockland, and Brockton. And then I think Abington was invited and is going to be joining on a voluntary basis, and Holbrook is also working with the Stoughton Quincy Collaborative, so they'll be joining also. So
we've got a collaboration of cities and towns working together, and not reinventing the wheel, but taking the best of what's working elsewhere and moving it forward in their communities.
Definitely.
That's great. What do you see with the recent? Obviously, Governor Patrick declared the opioid, heroin epidemic public health issue. Has there been any additional fundings that have become available to agencies such as BAMSI to help and assist in this program? We have been lucky enough that when the crisis started to really emerge and the Bureau of Substance Abuse Services or the Department of Public Health needed to take some action, we were already in place in a couple of communities and understaffed. And they were able to give us some extra dollars to go hire the staff that we have right now to be able to kind of head that off. And we were kind of sent in the direction of some of the more publicized overdose fatalities and be able to bring some services right away. And then kind of subsequently, we've been invited to participate, or our active drug using clients were invited to participate in the Governor's Council Task Force focus groups. So we were close enough to Boston to be able to bring our folks in and out with respecting the need for timeliness around their addiction.
so that our folks were able to contribute to the focus group of active users for the Governor's
So this
Council.
is feedback to the task force from the actual addicts themselves.
Yes.
That's fascinating, because you don't hear about that.
No,
you hear
that's
about the
very
public...
small. It's
that...
very tiny in the report, but they listened to everybody, including the active users, and they went to the Boston Public Health Commission, and we model our program after the Boston Public Health Commission. Their needle exchange, we don't provide needles on site at our place, but we do the same exact things otherwise. And we were able to bring our folks in just because of our proximity to Boston. It was, they had to be on time. We got in the car. We had to get there and leave promptly so they could come and do their thing when they got back.
And that goes back to the trusting element that you have to have when you're out there in the field working with the different individuals out there, that you built that trust and they felt comfortable enough to say, yes, Heather, we can come and share with the task force.
Or I felt comfortable enough with them to put them in my car to bring them to Boston, because taking the train to the Boston Public Health Commission is not really feasible. You'd need to take a train, 2 buses, and that wasn't happening. So we were able to participate in that way, and then just this past week we were able to participate in a roundtable hosted by the Commissioner of the Department of Public Health around opiate addiction. So I went in with the Stoughton Coalition, the Oasis Coalition, and sat with their police chief and sat with the 2 sergeants who do their Narcan training, and we were able to participate in their regional collaborative discussion with the Commissioner. So that was, we've had some input into how some of these things are going to play out, and a lot of our folks, we brought 2 out of the 8 individuals who participated in the active focus group. So
excellent.
They definitely let the needs of Brockton be heard. So, and the greater Brockton area, because they weren't both from Brockton.
If you had a crystal ball and you could look into the next year, what would you want to see happen?
That's almost next week. So,
well, fiscally speaking, it is next week, right?
I would love to see just the treatment system set up a little bit differently. I don't think intervention-wise that we could be doing anything differently or more efficiently, because most of our programs are being looked at internationally, ironically enough. Massachusetts has taken the forefront in just about everything from HIV and Hep C response to overdose prevention and nasal Narcan. But the treatment system wasn't designed for this new cohort of individuals who have co-occurring illnesses, who've been using since before their brains were fully developed, who have a chronic opioid addiction, which they're starting out really young. And the treatment system was set up for older opiate addicts and or alcoholics. Those are the 2 medically detoxable drugs that people were going into treatment for, and it's not set up for the cohort of individuals that we have going through with a chronic opioid addiction. And looking at the bigger public health spectrum, you're also looking at the fact that these folks, if they haven't gotten their behavioral health and their mental health sort of squared away, they're also going to need livers, but nobody is going to want to cure their Hep C for $1,000 a pill if they're going to go reinfect themselves and or potentially put themselves in overdose way. It's sort of a complicated system, but I think they're taking a really good look at...
The treatment system kind of has to adjust with the change in the way the drug addiction is changed. Right?
And I think the mental health piece plays a huge part in that, because the cohort of individuals who are like the 40 and 50-year-olds with opiate addicts or the alcoholics, their brains were fully developed, and a lot of them knew if they had a mental health diagnosis, and then they would go to what they call a dual diagnosis program, or a hospital program that was mental health with a secondary of substance abuse. And you're looking at a lot of folks who are going straight into substance abuse treatment for the physical dependency, but not getting the mental health treatment for what's often a compulsive behavior. So they might be self-medicating pretty consistently.
Well, we're kind of running out of time here right now, believe it or not.
That's
it has
awesome.
gone by, 28 minutes flies by here. I want to thank you, Heather, for coming in and sharing with us the changes that you've seen out there in obviously the addiction population, and then updating us on the Cope Center's services that are out there as well as part of BAMSI. On behalf of all of us here at A Deadly Silence, thank you for being with us, and we'll see you in our next episode.